But thank you for joining me. Is this good, Jen?
Perfect.
Wonderful. Okay, so thank you for having me. Thank you for putting up with reality. We're all living in reality right now, so let's embrace it. I just want to say it's such an honor to be invited to be part of anything that Pain BC does. Like, since I entered the field of pain, I looked to Pain BC as such, and I still do, as such an example of excellence and just such a template, like of how we should do pain advocacy and pain work in this field. So thank you, Jen, for inviting me. It's been so wonderful to get to know you and connect with you. So today I'm going to talk about an area of work that I've been kind of building for a long time. I realize it's been a long time now. I started this work back in graduate school, and it's really grown. And I'm going to talk to you today about the work I do in Calgary, but it started before here. So me and my wonderful trainees, I see Alex, my brilliant PhD student on the call. Thanks for coming, Alex. We do our work at the Alberta Children's Hospital in Calgary, Alberta. So we are in the foothills of the beautiful Rocky Mountains. And all of our work happens at the Children's Hospital in the Viradell Pain and Rehabilitation Center. I'm a psychologist. I am in the Department of Psychology, but I think this is important because I just want you to know that all of our work is very patient-centered, or I should say people with lived experience centered. We do our research, across the hall from where kids get therapy, psychological therapy, rehabilitation, physical therapy. And so I hope that you'll see that what I do is not in the ivory tower and in academic journals, but all of the work that we do is really aiming to understand why does pain become a problem, and how can we actually do something about that to improve these kids' lives. So I may be preaching to the choir, but I'm probably going to go out on a limb and assume that many of you focus on adult pain. So it may be surprising that pediatric chronic pain, so pain lasting 3 months or more, is actually experienced by about 1 in 4 Canadian children. So these are things like headaches, abdominal pain, musculoskeletal pain, pain often that arises in the absence of injury. And this happens around the point of puberty, at adolescence. And so it's been coined a modern public health disaster. It affects a lot of kids and it costs a lot of money. So it costs about $19 billion a year in childhood. And what we know is it can really rob a child of a normal, typical childhood that they deserve. So it can get in the way of social functioning, emotional functioning, all kinds of functioning. But what we know now in the last 10 years is that this is not just confined to childhood. So kids who have chronic pain in adolescence, 2/3 of them are likely to become adults with chronic pain. So that blows a $19 billion problem into a $60 billion problem. And pain is not just about pain. So kids who have chronic pain are at heightened risk for developing internalizing mental health disorders like anxiety, depression, PTSD. They're at heightened risk for developing opioid misuse in adulthood. And we've shown through nationally representative data in the United States that having chronic pain in adolescence in and of itself is a risk factor for developing anxiety, depression, PTSD, like mental health disorders into adulthood. So it's a problem that we need to understand, and it's a problem we need to do something about early to prevent this long-term course. Now, what does this have to do with this baby? Well, in the next 40 minutes or so, although I had tech difficulties, so I'll try to speed it up. I'm going to show you that or try to convince you that how pain is managed early in life, even from the first few days of life, can set the stage for how pain is experienced later in life. And I will tell you that it may shock you that I was born in 1981, so I am shy of 40. When I was born in 81, if I was born with, say, a congenital heart defect, the doctors would have paralyzed me, given me paralytics to undergo open heart surgery without any pain management. And it took the brave efforts of mothers and people who had actually lost children through these acts and these beliefs to say that early pain actually can set the stage for future pain. And it was widely believed that babies couldn't feel pain. It was also widely believed that babies couldn't remember pain. So I'm going to show you how just in the last 40 years, we have learned so much about how early life pain not only influences pain in the future and health in the future, but it actually leads to a memory of pain that can play a powerful role in future trajectories. Now, this area was really established by Anna Taddeo and colleagues. So they did a study of babies born of diabetic mothers who had to get repeated heel lances. So that's like needles in the heel of the baby to do blood testing. And they compared those babies to babies who weren't born of diabetic mothers, okay? So they didn't have these early painful procedures. And what they found was the babies that had had these early unmanaged painful needle pricks, when they followed them up, so this was in the first few days of life, when they followed them up a few months later and looked at when they were getting a vaccine injection, when the nurse was just gently, cleansing the skin to get them ready, not painful, the babies who had undergone those unmanaged painful procedures, several months later, when they were getting those vaccine injections, just at the point of cleansing the skin, those babies showed more pain and more fear. They showed anticipatory fear and pain and distress, indicating that they may have developed an implicit or an unconscious memory of those early procedures that really set the stage and influenced how they experienced or anticipated pain in the future. Another study in the late 1990s came out. This was by Steve Wiseman and colleagues who followed a group of kids who had cancer. And these children had to get repeated bone marrow aspirations and lumbar punctures. So a pretty big needle in the spine, and it's painful. And at the time, children's pain was not being managed, okay? So they would undergo these painful procedures without any pain management. So they randomly assigned the kids to either getting pain management, fentanyl, or no pain management. And you can see here that the kids who had the fentanyl, whose pain was managed at those painful procedures, had less pain, okay? Not surprising. Now, after that first procedure, they said, this is unethical. We need to give all the children pain management. But you can see that, after that first procedure, children who didn't have their pain properly managed the first time never derived the same benefit from pain management as the children whose pain was properly managed, raising the suggestion that not only is a child's pain experience remembered, and those memories may influence future pain, but it may actually influence whether or not children respond to pain management later. So why is this important? Well, this is from a video from Anna Taddeo's Helping Kids and Adults Pain initiative that I'm part of, where this is a video of a mother who brings her toddler. Now, this child cannot really talk. The child doesn't really have language, okay? She's about 1. And she goes into the pediatrician's office where she had previously had a needle procedure. And as soon as that child enters the room, she starts crying. She starts showing that she's scared. She shows distress. And the mother looks at the camera and she says, I think she remembers the last time. Is that possible? And so what I'm going to convince you of, I hope, is that how pain is managed very early in life is indeed remembered and does indeed affect how a child experiences pain in the future. Why is this important? Well, what could be more timely than needles right now? I'm happy to say I got my vaccine injection last week. We're about to have billions of children ready for vaccinations in the next year. And what we know is about 1 in 10 adults who have a needle phobia, so an extreme fear of needles, actually can root that back, most of them, to a poorly managed pain experience in childhood. So these experiences, people say, it's just a little needle, get over it. Well, these experiences can actually, they're remembered. The pain is not over when the needle ends, and this can actually influence fears and avoidance of medical care into the future. And if I were to summarize about 20 years now of research, including some of my own, but some of other colleagues, I can say that, whether we're talking about a child has cancer, who's getting like a lumbar puncture, or healthy children who are putting their hand in cold water in the lab, that's how we understand pain in the laboratory, or whether we're talking about adolescents who are getting major surgeries, how children remember pain is one of the most robust predictors of how they'll experience pain in the future. What's really cool, I think, as a psychologist, is that memory is not like a tape recorder. So we have all experienced pain. We all have memories that form who we are. But how memory develops is very fragile. It's susceptible to distortion. So you can't play back an experience and have it recounted exactly as it happened. These memories are susceptible to distortion. And we know that about 1 in 4 people, especially kids, will develop what I call a negatively biased memory for pain, or a distressing memory for pain. So these kids are remembering a painful experience as being worse, more scary, more painful than it actually was. So a classic example, Jen, I'll pick on you. If you just got a needle and I asked you, oh, Jen, how was the needle? How much did it hurt? And you said, oh, about a 5 out of 10. If I called you 2 weeks later and asked you, remember when you got your needle? How much did that hurt? If Jen had a negatively biased memory, she would say, oh, it was an 8 out of 10. It was horrible. Like they had to hold me down. I cried. She's remembering it as worse than it was. And this is important because it's those kids who develop these negatively biased memories that then go on to develop worse pain and worse fear and worse distress in the future. And we're trying to figure out who these kids are. So we know that how procedures end, how painful experiences end, is important. So this was from a really cool study by Joel Katz, a mentor of mine in Toronto, who followed a group of men who were getting colonoscopies. And they randomly assigned the men to either have a positive ending or as normal. So they removed the device slowly for a less distressing ending of the procedure, or they just removed the device as normal. These men had the same pain experience throughout. So it was equally as painful. The only difference was whether or not the ending of the procedure was less or more distressing. And they found that For the men who were randomly assigned to receive the less distressing ending, and I understand there's a pun here, those men were more likely to develop more positive or accurate memories of the procedure, and they were more likely to come back for a repeat colonoscopy. So this really shows that how procedures end can play a really important role in how that pain experience is remembered and your future adherence. We know girls are more vulnerable to developing these negatively biased memories than boys. We know that anxiety is a huge culprit. Okay, so if you are anxious, anyone? I don't know, it's pretty common. If you're anxious, you believe the worst is going to happen. You expect things to be really bad. And if you expect things to be really bad and you're anxious, you're more likely to remember a painful experience as being worse than it was. So I got really interested. I was doing this work in needles and in the lab and the cold presser task and all of that, but I got really interested in this notion that memory for pain, how people remember pain, may be a reason why pain transitions from an acute, a short lasting, to a chronic state. Because we were seeing that kids who developed these negatively biased memories were more likely to have more pain in the future. Well, is this one of the reasons why pain may become chronic? So we became interested in surgery because, you know, about 10 years ago, this is when this area of work really started exploding. Why is this an important context? Well, anyone who lives with pain or works with people with chronic pain knows that oftentimes this problem comes out of the blue, right? Like kids will wake up and they have headaches. It's not like they had an injury and they develop pain. So as a scientist, it's really hard to try to catch these kids before pain becomes a problem. But surgery is an area where we know many of the kids don't have pain before surgery, like with spine fusion pectus repair. But we know that about 1 in 5 of these kids will develop chronic pain. So we started researching this population to understand the role of memory in the development of pain and chronic pain. So we had a small group of kids who underwent adolescence, so around the time where chronic pain develops, who were undergoing these major surgeries. Okay, so this is spine fusion, is where they manipulate muscles and they put a rod in the back to straighten the spine. Okay, it's very painful, and oftentimes these kids don't have pain before surgery. We also did pectus repair, a similar chest surgery. We asked parents and kids about their catastrophic thinking about pain. So this is just a thinking style. So it's the tendency to magnify how bad pain is, to ruminate about it, play it over and over again, and to feel helpless about pain. So it's a thinking style. So we asked parents and kids about that before surgery. They had their surgery, they rated their pain. We called them on the telephone. We did interviews to ask them about their memories for pain, and we could compare that to the previous pain, so we could see who had developed those negatively biased memories. And they've been rating their pain for years. And so we could see which kids developed chronic pain or not. And the first study really showed that just the way that parents and kids were thinking about pain prior to surgery was a huge predictor of the development of their memories for pain. So children who before the surgery felt helpless about their pain tended to develop these negatively biased memories. And parents of these kids who tended to magnify how bad the pain was of their child, who tended to think about their pains, their child's pain over and over again, their children were more likely to develop these negatively biased or increasingly distressing memories for pain. And this was controlling for anesthetic use, initial pain reports, all of the biological stuff that people think is really important. it really shows the power of how we think about our pain in shaping how we remember it. In a subsequent study with many more kids, over 200 kids with Joel Katz and my colleagues here, we also showed that if kids are more anxious before surgery and in the hospital after their surgery, they're more likely to develop these distressing, negatively biased memories of pain. But the real million-dollar question is, okay, once those memories are developed, are they playing any role in whether or not kids develop pain problems? And we found that in this study, following the same group of kids with surgery, we found that kids who developed these negatively biased memories, they're remembering the surgery as being more scary, more painful than it actually was, they were more likely to report higher pain at 4 months post-surgery, precisely the point where pain can transition to an acute, to a chronic state. So this really suggests that, I'm not saying this is the only reason why chronic pain develops. This is a hugely complex problem. I'm saying that the memory for pain, this thing that is so malleable, that's so fragile, that can be changed, is one reason why some children develop pain problems in the future. So this is a beautiful picture. If I was with you in person, I would scan the room and say, does anyone know what this is? This is our beautiful hippocampus. It's the little part in your brain, in your limbic system, that's responsible for memory. And, a lot of my work had focused on how children remember pain by asking them, what do you remember? Think back when you got your needle, their language. But I got really interested in the brain. And this was inspired by a researcher in the United States, Vanya Apkarian, who's one of the leading pain imaging researchers in the world. And he had done some really interesting work with adults who had subacute, so not yet chronic, low back pain. And he scanned their brains to look at how the hippocampus, this part of the brain that's responsible for memory, may be changing when pain transitions from an acute to a chronic state. And what he found is that as you looked at these adults who had, subacute low back pain, and you followed them about a year into the future, seeing which ones developed chronic pain, there were changes in the hippocampus, the memory center of the brain. There were decreases in connectivity, functional connectivity to the dorsolateral prefrontal cortex of the brain. Also, they found that individuals in this group of adults who developed chronic pain, low back pain, they found that the individuals that developed those negatively biased memories for pain, so they're remembering it as being worse than it actually was, that was related to changes in their hippocampus. So there was an expansion of their, the morphology, the structure of this part of the brain. So really linking together the memory that you can tell someone and what's happening in the brain. So this got us really excited because we were like, okay, we know that memory plays a role in the development of chronic pain, but what's happening in the brain? And no one has looked at this in kids. So my amazing former postdoc, who's now a full, she's a professor, assistant professor at the University of Calgary, Jill Vanal. Look out for her, she's amazing. She took a group of kids who had chronic pain, compared their brains to a group of kids who didn't have chronic pain, and she found that indeed there were differences in the sizes of the hippocampus, that area of the brain responsible for memory. She also found that in these groups of kids with chronic pain or without chronic pain, there were decreases in functional connectivity from the hippocampus to the dorsolateral prefrontal cortex, what we saw in Vanya's studies. And there was an increased connectivity from the hippocampus to the amygdala, the fear region of the brain. Now, this makes sense, right? Because I've just showed you how anxiety and fear are really related to these negatively biased memories. So I'm really happy to say, after lots of work and lots of time and lots of perseverance, we received funding from the Canadian Institutes of Health Research to follow a large group of children undergoing these surgeries to really look at what's happening to the brain, the hippocampus, in the transition from acute to chronic pain, and what's the role of memory in that. And I can see my amazing patient partner, Janice, is on the webinar. Janice is a key collaborator and co-investigator in this work. So what does this have to do with little kids? Well, I am proud to say I'm a mom of 3 7-year-olds. Yes, they're triplets. And I was raising my kids and watching them. And any parent in the room, or any auntie or uncle or anyone who has children in their life, knows that pain is ubiquitous, right? Like, kids are falling down, experiencing pain all the time. And we got really interested through my own experiences, but also in watching the kids that we work with, about how memory for pain is really dynamic and changes in the early childhood to adolescent period. There's something really unique about children's memories for pain and memories in general, in that in the golden period, which I called early childhood, so when kids are about 4 to 6 years old, a lot of things are happening developmentally. So they are developing theory of mind, understanding that you can have a perspective that I don't have. Their language is blossoming. They are talking nonstop. I can attest to that. And parents are super influential on children in this early period of childhood. They're also really influential on their memories. So, you can tell a child that something happened, and they can actually adopt that as if it's a memory of their own. Now, that would be unethical. I'm not suggesting anyone should do that, but I'm saying it just goes to show that there is science to show that how children develop memories is very plastic. It's very malleable. And so we got really interested in how the ways that parents talk to kids, okay, may shape how they develop their memories for pain. Because ultimately, we want to understand how to change these memories to be more positive, accurate, to set kids on a better path. This is me and 2 out of 3 of my kids. Georgie in the pink there, Soleil in that amazing jungle H&M print. This is me in my lab, and this would be similar to what we did in this study with kids. We basically took a group of 4 to 7-year-olds who were undergoing surgery. And I'll tell you about that in a minute. And we had parents come back with their kids after the surgery to just talk with their kids as they normally would, to reminisce with them, to see how the ways that parents talk to kids about pain may influence how children remember pain. Now, we know from years of developmental psychology literature with kids that the ways that we talk to our kids about pain and stressful events is not equal. So some parents ask kids really open-ended questions. They pull for a lot of details. They follow in on the child's lead, and they talk about emotions. They don't shy away from talking about difficult things. But there are other parents that tend to ask more repetitive, yes, no kind of questions. And we know that parents who tend to talk to kids in these more open-ended, elaborative ways have kids who tend to develop better memories of those stressful events. So we followed a group of kids young kids, 4 to 7-year-olds who were getting these tonsillectomies. Anyone who's had one knows it's painful. And we asked them to rate their pain in the hospital when they were home. We got them to come back to the lab to reminisce with their parents as they normally would about this experience. We coded it to see how elaborative they were, what they were focusing on. And then a couple of weeks later, we asked parents and kids what they remembered about that surgery. So what we found was basically parents. So it didn't really matter in this young age group how anxious the kid was. If mom or dad, and we had a lot of dads in this study too, I'm proud to say, if mom or dad were more anxious before the surgery, their kids were more likely to develop more distressing, negatively biased memories for pain. We also found when we compared how parents talked about pain, like the surgery, to other kinds of distressing things, like traumatic things, sad things, interestingly, parents are really good at talking about sad stuff, but they don't reminisce with kids about pain in adaptive ways, which is really interesting to me. And importantly, we found that how parents talk to kids and reminisced with them about the surgery, okay, had a really important role in how kids remembered that painful experience. Parents who tended to be more elaborative, who tended to talk about emotions, had kids who developed more positive or accurate memories. Parents who focused more in those discussions on the pain, it hurt, it stung, you know, they focused more on the pain, had kids who developed these distressing memories for pain. And so we have really argued that, you know, this is exciting because it shows that, yes, we all remember pain. We remember pain from the first few days of life, and those memories can influence how we experience pain in the future. But this also shows that those memories can be changed. If anxiety is a predictor of poor memories or distressing memories, we can do things to alter anxiety before painful experiences. But we've also showed that how parents talk to kids can also reframe the memory. So we have argued that, you know, we should be doing something about this. Like, we talk a lot about giving numbing cream, distraction, you know, managing children's pain in the moment. And of course, we need to do that. But what happens in the car ride home? What happens around the kitchen table? How can we be using just our conversations with kids to actually also alter their memories and their experience of pain? So this has been done, okay? So there's been 3 studies to date that have looked at whether or not we can talk to kids in a way after a painful experience to reframe how they remember pain. So there's been 3 trials, one of children with cancer undergoing these lumbar punctures, one of 5-year-olds undergoing vaccinations at their pediatrician's office, and another study of early school age children undergoing dental anesthetic injections for dental procedures. And essentially all of these studies looked at the kids when they were undergoing these painful procedures. And afterwards, they talked to the kids and did 3 things. They emphasized anything positive that happened. They corrected any negative exaggerations in memory. So if the kid said, oh, I cried for 10 minutes, you know, you would say, actually, you cried for a minute, but then, and pivot back to the positive. And these interventions helped children increase their confidence in their ability to manage pain. So they boosted their self-efficacy. You can do it. You did such a good job. You managed your pain, right? It ranged from a simple sentence to about a 15-minute discussion with the kids. And they followed the kids up later to see how they remembered the pain, and in some studies, how they experienced pain in the future. So this is an example from one of the simpler studies of the kids who got vaccine injections at their pediatrician's office. So half of the 5-year-olds were either randomized to a pain denying group or a pain neutral group. So if the kids after the vaccine injection were assigned to the pain denying group, a researcher went to their home and they said, you know, when you got your shot, you were a really brave kid. They said you didn't cry at all when you got your shot. It was like it didn't even hurt you at all. That's it. So they said that on 3 occasions over the course of a year. The kids in the other group, the researcher went to their home and said, the day you went to get your shot, they said you first came into the office and the secretary talked to your mom. So didn't talk about the pain or distress at all. And just by providing that feedback, the kids who got the pain denying feedback tended to develop more positive and accurate memories of that needle procedure. And based on all of the work that I've shared with you, I would bet that the kids that got that feedback, that were talked to in that way, not only developed more positive and accurate memories of the procedure, but they probably, when they had to go back to get their flu shot next year, probably handled it in a more adaptive way. They were probably less distressed, right? Now, I will say that I consider this study to be unethical. So I think that you should never lie to a child. You don't need to. You can reframe a memory for pain to be realistic. You don't need to deny what actually happened, but I'm happy to discuss that at the question period. So all of those interventions focused on researchers, right? And clinicians. But we thought, wow, well, we know that parents are so powerful and influential in children's pain and their memories. Let's see if we can develop an intervention to teach parents how to talk to their kids in different ways to kind of reframe that memory. So this is led by my brilliant PhD student, Maria Pavlova. She and I developed this intervention where essentially we followed kids who were undergoing those surgeries, young kids, and we taught parents after the surgery how to reframe their kids' memories for pain. 3 principles. 1, shine your spotlight of attention on anything positive that happened. That could be a friendly nurse. That could be someone who visited you and brought you a toy. Anything. Just when you're talking about what happened, focus on anything positive that happened. 2, let's be realistic. So if you catch your child, mom or dad, remembering something as worse than it actually was. So if your kid is remembering them crying for 10 minutes, but it was actually like 30 seconds, you know, you're going to point out to them that it wasn't that bad. You know, they did cry. You're not denying what happened, but you're pivoting them back to the positive, right? And correcting the negative exaggeration in their memory. And 3, very simple, boost children's self-efficacy. Show them how brave they were. Show them with specific examples of how they were actually able to manage their pain back then. Wow, do you remember you took deep breaths? That's really helpful. Do you remember you were watching the show on mom's phone? That's called distraction. That can really help. So just these 3 simple principles. We talked to parents who were undergoing this tonsillectomy surgery. Okay, same design. Kids came in for the surgery. We rated their pain. We looked at their anxiety. And then 2 weeks later, they came into the lab and half of them were randomly assigned to either get those instructions to how to reframe the memory, or they were taught how to play with their kid. It was a control group, so no memory intervention. And then a week after that, we called the kids and we asked them to remember the pain that they had experienced at the time of the surgery. And we found that just in 15 minutes of teaching parents how to talk to their kids using these 3 principles to reframe their memories, children who received the intervention and these instructions they developed less negatively biased memories for pain. They were remembering the surgery as being less painful and less scary than it actually was. And so this is a small study. We have much more to do, but we're really excited about the potential of this. And me as a child development researcher, I find it very compelling to think about how can we better manage pain early in life, before adolescence, before, we have to manage it throughout the lifespan, don't get me wrong, but could we set these kids on a better trajectory by harnessing their social circles, by working with their parents, who are the best advocates in the world, to really, set them on a better trajectory for pain in the future? But I don't want to end there. I'm almost done. I want to say that, it's not all about memory. So I think there's a lot we can do about reframing kids' memories, talking to them in different ways. But the more we can manage pain when it's happening, the less likely these kids are going to develop these negatively biased memories. So this was a study by Lindsay Cohen and colleagues that showed that if you looked at adolescents who were getting these vaccinations, and there were 3 groups, they either got no pain management or they got numbing cream or distraction, so effective pain management. Even though in this study there was no difference in their expectations or anticipation of pain or their experience of needle pain, kids who got proper pain management at the time of the needle procedure were less likely to develop these negatively biased memories for pain. So this just shows how we really need to manage pain in the moment to kind of buffer against long-term outcomes, memory, and chronic pain being, and avoidance of medical care being among those. So that brings me to the end, to the question period. I'm really excited to chat with you all. I want to say that I am the messenger of this work. So it's really driven by brilliant students, trainees, postdoctoral fellows, clinicians, patient partners, people with lived experience. And so I don't want to take the credit for this. It's really a team effort, and thank you for having me and listening.
Thanks, Melanie. That was fascinating. Excuse me, fascinating. Okay, we have a couple questions. And please do put your questions in the Q&A. I'm sure you've got a lot of them from that presentation. So let me see here. So Beth is curious as to the role of physicians and healthcare providers. So when someone receives calls from parents whose children's pain is not being managed, for example, using essential oils during pancreatitis attack, and in the US, many physicians are fearful of using opioids. If there are other strategies, wonderful. However, in situations such as pancreatitis and sickle cell, often one does need an opioid. I worry about these children and youth that this will impact them. And physicians are not all aware of what you've covered. So hang on, there's clarification. What is the impact of healthcare providers who do not take steps necessary to address pain or minimize the trauma of procedures? For example, holding children down for shots. What's the impact of that?
Yeah, no, great question. And so I will first say that I totally promote and buy into a multimodal approach to pain care, that psychological strategies are one, but that's not to say there are not times where pharmacological or physical strategies, either adjunctively or on their own, are super effective. So I just want to say that first. You're raising a really important issue around medical trauma, right? and the iatrogenic effects of sometimes well-intentioned, sometimes not, care, right? And I will say I have a child with a chronic illness who, you know, even despite all my knowledge and, you know, research, and there have been times in that encounter where I have not managed his pain in the way that would be beautiful in a presentation and idealistic. And so, number one, we know that what we do, and especially around the context of pain and procedures, can indeed be traumatic. I'm working with a researcher actually who used to be at UBC. We recruited her, I'm happy to say, although we're all teams here. Tammy Dewan, who is studying medical trauma among parents of kids with medical complexity. And we're really learning that some of these things that you're talking about around restraint and, you know, playing a role in these unmanaged painful procedures, they not only can lead the kid to developing fears and avoidance and phobias of medical care, but that can also have a hugely damaging effect on parents and their own mental health. And there's a whole trauma context to this. So this is why I think what BC Children's, Pain BC, Alberta Children, like what SKIP, like what we're doing to try to really, you know, fold proper pain management into the culture of every encounter for every child in every wing of the hospital is so important, because not just to manage the pain, but to manage the trauma, not just of the child, but of the parent. So I guess my short answer after my tangent would be, yes, what we do as clinicians can play a major role. We have a lot of tools in our toolbox. The stuff that I'm doing is one intervention that we can actually empower parents to use. That's why I love it. It's like when the stress and everything's over, what can we do? But we need to really think about all of the tools in our toolbox and really be aware that what we do clinically with these kids can be traumatic or not. Managing pain can be the antidote to that. But I think we also need to think about anxiety and mental health too.
So Melanie, just to follow up from that, it's my own question. So what would you say to people who have children who have they've undergone these painful procedures, they've experienced medical trauma, their pain has not been managed in the moment, and they're older kids now, like maybe they are in their teens or in later childhood. Is there anything, and when parents are kind of grappling with the effects of this history, like what would you suggest to those folks?
Yeah, that's a great question, because I think sometimes when I present this, it seems like, if the negatively biased memory is there, you're doomed. You're not. So this depends, Jen, on the level or the degree of distress and fear. So when we have sort of levels of fear that are almost phobic, okay, that requires a psychologist. It requires a higher level of care. So a lot of the ways that I present this work is very preventative. That's not to say that kids can't develop fears or something goes wrong. I can say for my own kids that's happened to me. And I think I have a budding, I'm kind of on the cusp of 1 out of 3 of them. He didn't have a good experience last time. So now I think, what do I do? Which is your question. So I think there's a lot. I think preparation, I think these memory reframing strategies are good, but I think we need to make the call when a child's fear and distress gets to a level where it's very phobic, avoidant, aggressive, which is driven by fear. That's when we need to kind of ask for help at a higher level. And there is help. There's great interventions, exposure-based interventions for, like, I'll use needle fears as an example, where a professional, often a psychologist, can work slowly to kind of get that child exposed to what's coming and get them desensitized or used to that feared stimulus. God, I sound like a scientist in a lab. That the thing that they fear. So what I'm saying is this: pain management, memory reframing, awesome when it's not a phobia.
Right. So you can even do that when the kid is older.
Yeah, well, and also, we should do this for every kid. That's what I really believe. Do it for every kid. And so that, because it's true that one poorly managed experience can lead to that. So this should not be reserved. It's cheap. It's not expensive. It's all parent led. It should be provided to every kid at every encounter. And the kids that do and will develop those heightened fears, there's help there. There are interventions we can do, but that's when we need to call in the big guns a bit and ask for the help. It's there.
Yeah, that makes sense. Thank you. Appreciate that. Okay, back to the questions. So my child has JIA, juvenile idiopathic arthritis, and requires weekly injections, which I don't think as a parent did well. And now she has a severe phobia of injections, but does great with blood work. Can this kind of pain experience affect other chronic pain situations like knee or back pain, for example, which sounds like she's developing now?
Great question. Number one, I'll say, just in solidarity, I don't know you, but I remember one time Jasper getting blood work and, oh gosh, everything I did was just not optimal, but I froze, right? Because so I think we need to have compassion with ourselves around this. It's a really interesting question. It's interesting that she doesn't mind blood work, but does mind this. It really shows the idiographic nature of fear. I'll give you an example. You could have someone covered in tattoos who can't get a vaccine injection, right? So sometimes all of this doesn't generalize from one thing to the next. There is no evidence that, say, a child's, experience of needles will lead them to develop back pain or chronic pain. So I will say there's no evidence of that. The surgery model that we used shows that memory or surgery experience affects post-surgical pain, but I don't want you to worry that one context will necessarily layer onto or feed into another context. Could it? Maybe. But I think pain is not pain, is it? When I have a migraine, that is very different than when I got my vaccine injection, which is very different than when I fell down and had a bike accident, So you raise a really important question. I just want to be honest that we don't have the evidence for it. And I will just say, to loop back to the self-compassion mom, which I am trying to be, it's okay if things didn't go well in the past. There's always a chance to change it. So just like one negative experience can lead to worse experiences, one positive experience can also change the trajectory, right? So
that is very, very hopeful message. I think all, us moms are pretty hard on ourselves.
I am. Hello.
Me too. Yeah. Okay, we're at 1 o'clock, but we've got a couple more questions. Do you mind, Melanie? Do you have a minute? And if folks can stay on, we'll get through this. Okay, so what are your best resources for clinicians and parents for knowledge and advocacy?
So, God, I don't want to give you a psychologist answer. It depends, but it does depend on the issue that you're interested in. So if you're interested in what should I do about chronic pain, I would highly advise the books by Tanya Palermo and colleagues. They wrote a parenting book, Tanya Palermo, Emily Law. Tanya's actually my postdoc mentor, amazing woman, amazing scientist, a fabulous book for parents about chronic pain. I don't know a good book about acute pain, but I will say I would highly advise you to follow the It Doesn't Have to Hurt campaign by Christine Chambers. I would also link you to Solutions for Kids in Pain, SKIP. They are an amazing organization that are fanning out evidence in blog posts and, you know, infographics and like resources. Those would be my leads for you. And please, SKIP is really what's really helping propel forward, and, you know, the work that we've all been doing for decades. And they're like, so what? How do we get this to parents? How do we get this to clinicians? How do we get this into hospitals? So I would highly advise follow SKIP, and you'll get lots of tentacles and leads through them. And we're always happy to share anything too, by the way. So reach out to us too.
Yes, and also to Pain BC, because we do have a pain support line, and we do have a social worker who is available to look around and do some research for parents whose children are in pain, or even healthcare providers.
Can I also plug something else that's really exciting? Is that we are developing, led by Jen Stinson in Toronto at Sick Kids, we're developing a pain portal which will provide free evidence-based pain care for kids, and linking them to issues if they have anxiety or depression or sleep. And so we're really working hard, guys, on trying to take this knowledge into applicable things that people can access for free. But yeah, Pain BC, yes. I mean, gurus.
Thanks, Mel. The portal, I've heard some things about the portal, and it's that's going to be a terrific resource.
Oh, it's and there's
really good.
There's a lot of momentum to actually, like, you know what, people are sick of just publishing papers, putting them in journals. Like, there's a lot of, I think the field is moving in, led by Pain BC and other organizations like you, like, okay, so what's the resource? How can we put this in the hands of people? And it's starting to happen for sure.
Yeah, and I think the children's pain is a particular bright spot, right, for getting that research into the hands of parents. It's really interesting, the work that Christine Chambers and you and Jen Stinson are doing around that. So
right?
Terrific. I did just put the links to the book by Dr. Palermo and to SKIP in the chat if people want to see. And then I think we have one more question. So Dieter van der Band says, hello from Germany. Thanks for joining us. Question is, what about teaching parents about graded exercise, motor imagery, activity programs after surgery for kids? Is there any research about the impact of this intervention on the transition from acute to chronic? Do you think this could be useful in pain management?
Yeah. Okay. So short answer, yes, right? Like to the physios out there, like, whoa, it's such an important part. And I think it's the movement, especially for highly fearful kids, that can really induce all of these, you know, emotions. And so I think that merging of psychology and physio is so important. I don't know of studies that have looked at physical interventions following surgery in terms of trajectories. We do have data looking at activity levels, though. It's not published, but looking at how active was a child and might that lead to, you know, worse or better pain outcomes after surgery. So I don't have an empirical scientific answer for you, but, you know, we know that movement works. We know that graded exposure works. And so I would say it's a very fruitful area. And gosh, if we could combine that with all the great psychological stuff, you know, with the pre-surgery anxiety reduction stuff of parents and kids, I think we'd be, you know, locked and loaded for a good outcome. So we need to keep doing the work in the area, but I think it's very fruitful.
Awesome. Well, oh, hang on, one more question. I thought, okay. Oh, I've seen, okay, so sorry, everybody. I put the book link in the chat and it didn't seem to come through, even though it looks to me like it has. So I'm just gonna try that. I'm just gonna try that again, hang on. Maybe that worked. Oh, I know why. Okay, I'm also gonna put the link to Skip and that should work. Okay, sorry about that. My fault. All right, thank you so much, everyone, for coming. This has been a really rich discussion. And Melanie, I am just so grateful to you for presenting this research. It's just like so fascinating and so practical and so applicable. And I think we can all kind of go forward and think, you know, we have an intervention we can use, first of all, and then just to see what's how the field is taking shape is just really interesting. Thank you so much.
Thank you. This is like, this actually made my week. Long story, but so thank you for having me. And yeah, happy to be on this. Thanks, Jen.
Thanks, Melanie. Bye, everyone. Thanks again
Bye.
for coming.